Whether we should exercise any caution in diagnosing PCOS, yes, I have already told this, because in puberty there will be some amount of anovulation right after the menarche, and 50 to 60% of the girls will show polycystic pattern on ultrasound. And as I said earlier, if you are not a gynecologist, if you are simply a radiologist, they will simply brand every case as PCO, right? And irregular cycle is a rule rather than an exception, because HPO axis takes its own time to mature. It will take sometimes, nowadays the girls are having menarche by around 10 to 11 years itself. And they take, sometimes I have seen 16 years, 17 years time to have a proper mature HPO axis and have a regular cycle. So in between, if we just brand them just because they have irregular cycles as a case of PCO, it will have a very bad traumatic experience on the girl. And they all nowadays Google out if I'm having PCOS, what are the problems that can I have, and they will get worried. So the same thing happens at the other extreme of the age. In the menopausal transition period, also before attaining menopause, there will be a period of androgen excess and there will be irregular cycle. So we should not jump and say, now you have developed PCOS. That girl will in fact slap you. She says, I have had 3, 4 children now. Why are you branding me as a case of PCOS? So just by what I'm trying to again and again highlight is that ultrasound picture can be misleading. We have to have actual enough proof of hyperandrogenism. And again, hyperandrogenism in the menopausal transition period is not uncommon. So there also we have to exercise caution. Otherwise, that lady will be worried that will I get endometrial cancer? Will I get diabetes? So we have to be very careful in branding anybody as having case of PCOS, because here there is no biopsy-driven diagnosis. In cancer, at least we can say final diagnosis is with the hands of pathologist. Whatever the pathologist says is the final diagnosis. Whereas here, there is nothing to prove histopathologically that you are a PCOS case. It's all clinical symptomatology, it's all the morphology, and it's all other things. So we have the ultimate verdict in our hand, and we have to be very careful giving that verdict. So my final take is that exercise caution while branding pubertal girls and those in menopausal transition as PCOS. Okay, so this is supposed to be the next question.
What are the causes for anovulation?
Yeah. So anovulation, we have heard many times in this last 20 minutes. So what is actually causing anovulation? There are two schools of thought. One school says it's a pure metabolic disorder, and that can explain everything. What do you mean by metabolic disorder? They say insulin resistance and obesity are the culprits. They are the main culprits of this anovulation. Whereas there is another school of thought which believes that the entire problem is because of a reproductive disorder wherein there is HPO dyssynchrony. After all, an ovulation is decided by the hypothalamo-pituitary ovarian axis. So why should you bring in metabolic disorder? But in the next slide, I'm going to show you the connection between the insulin resistance and HPO axis. That is like a combined explanation for anovulation. Now let us go little slowly, step by step, to understand this. The people who say metabolic disorder is the root cause of the anovulation, they start with insulin receptor dysfunction. This is the one which is giving rise to problem in the pancreas. As a result, the pancreas will secrete lot of insulin. There will be hyperinsulinemia. It all started with the insulin receptor dysfunction. This hyperinsulinemia will have an effect on the liver in the sense it will reduce the serum hormone binding globulins, what we call SHBG. As a result, what happens? There will be increase of free androgen. So that is one way or one route. The other route is I'll come to hypothalamo-pituitary ovarian axis as promised. The hyperinsulinemia will not only act on the liver, it will act or influence the pituitary in such a way that pituitary will be partial towards LH. So it will secrete more of LH. Now, what happens if there is more LH? There will be a stroma that will be again influenced by hyperinsulinemia. The combined result of LH, rise in LH and stromal effect, the theca cells will produce androgens. Now, insulin is not happy just influencing liver, pituitary, and the stroma. It will also influence the follicles. How? It is the follicles which will convert the androgen into estrogen by aromatization. This is also reduced thanks to hyperinsulinemia. What is the net result? There is increase in the androgen. Now, one more thing the insulin does, it will influence the adrenals as well. And there is an increase in DHEAS. What is the net effect? There is androgen, androgen, androgen all the way. When there is androgen, that is the cause of anovulation. As you can already see, there is increase in LH and there is decrease in the estrogen. But the second school, which relies on HPO axis dyssynchrony, they will blame the HPO axis directly. How? This is the usual thing that happens, what I call dancing of the hormones. But in cases of PCOS, there is steady state of increased LH, decreased FSH, and there is decreased estradiol. That's why there will be persistent anovulation. So finally, if you ask me what is my take is you cannot side with any school of thought. It is probably a mixture of both in most of the ladies. There is some amount of hyperinsulinemia, which will affect the HPO axis, and the HPO axis itself is not behaving properly. Net result is excess androgen and anovulation.
Prasad sir can have the next question.
Good afternoon. Thank you, Priya Madam, for involving and inviting me for the webinar. As we were discussing insulin resistance, and we have covered many points about it, but how do you check the insulin resistance? And should we check it in all cases as a routine
Yes.
investigation in PCOS cases?
Yeah. So actually, we left that point there and we jumped into another point of anovulation. So we are coming back to insulin resistance, how to check it and whether to check it in all. I already mentioned in the previous slide or discussion that the best method to check the insulin resistance is OGTT only. And as Madam correctly said, OGTT is easier than estimating the insulin and doing all sorts of calculations. So what are the indications for testing insulin resistance through a OGTT? Yes, if the girl is obese or lady is obese, we all know obesity is one of the indicators of diabetes, which in other words is an indication of insulin resistance. Second, if there's any evidence of premature adrenarche, we all know what is, there is pubarchy, adrenarche, and then there is menarche. So if there's any evidence of premature adrenarche, that case definitely asks for a testing. There are irregular cycles beyond 2 years of post-menarche. In fact, I would like to extend and relax it beyond, let's say, 4 to 5 years after menarche. As I said, nowadays, the girls are achieving menarche at a very young age group. So no need to test for insulin resistance even at the age of 12, 13. We can happily wait for at least 4 to 5 years before testing them for insulin resistance. And In case there is severe hirsutism and severe acne or alopecia, we have to estimate the androgens. And if the androgens are more than 150 nanogram per DL, this is an indication to do insulin resistance, because one of the slides I showed you, insulin is the starting point of increased androgen through liver, through pituitary, through follicle, through adrenals. Whichever way possible, it is the insulin which is increasing the androgen. And of course, the batch test is 75 grams OGTT, which is prescribed by WHO. To answer your next question, OGTT should be done in all high-risk patients. I've already told you who are the high-risk patients: those who are having obesity, those who are having excess androgen, those who are having premature adrenarche, those who are having irregular cycles for a long period. Others, you can actually do either an OGTT or simply fasting blood sugar, because OGTT takes 3 blood samples, right? You have to go fasting, and then they'll give you glucose 75 grams, and then 1 hour, 2 hour. Instead of that, if the girl is reluctant, you can simply do a fasting blood sugar. That will be a good indicator. Or you can simply do HbA1c, which will tell you actually how has been her sugar for last 3 months. So this is good enough. OGT is a must for all the adult women who are planning to conceive. Just before conception, you must do a OGTT. My take, finally, to answer your question, sir, a 75 gram OGTT is the best method of testing for insulin resistance, and it should be done in all obese and the high risk girls. But it need not be universal, only high risk girls.
Thank you, sir.
Thank you.
Dr. Vijaya ma'am, can we have the next question?
Good evening. Thank you, Dr. Priya, for giving me this opportunity. Dr. Pai, you are explaining the PCOS so nicely and at the molecular level. So whenever we say PCOS, it is the hyperandrogenism. So my question to you, so should we check for the androgens? And if we want to do it, then which kind of androgens will do the investigations?
Yeah. So yes, right from the beginning, I've been telling that hyperandrogenism is the hallmark of PCOS. So logically, it appears as though we have to check for the androgens. But the problem with that is the estimation of testosterone, or whatever androgens, what we say. There are 2 types of androgens. One is ovarian origin, which is androstenedione or testosterone. Other one is adrenal androgens, which is androstenedione or DHEAS. All androgens can produce PCOS morphogenesis, there is no doubt. But the recent thoughts with testosterone estimation is that the calculated free testosterone is better, or a free androgen index, or calculated bioavailable testosterone. The moment I say all these things, it sounds very complex and difficult. Yes, it is true. To add to the complexity, we must actually have high quality assays such as liquid chromatography, mass spectrometry, or extraction chromatography, immunoassays. They should be done. Direct free testosterone assays such as radiometric or enzyme linked assays preferably should not be used. Now, looking at this slide itself, we get scared and we get confused. What testosterone should be done? There is something called free testosterone, there is free androgen index, and then there are so many assays that are doing. So practically speaking, if you can get this high quality assays, yes, go ahead and get it done. But if you do not have clinical evidence of androgenism, hyperandrogenism is more than enough. That is hirsutism and acne. This is as good as having a biochemical proof for hyperandrogenism. Some more thoughts. Androstenedione and DHEAs could be considered if total or free testosterone are not elevated. That means if the ovarian androgens are not elevated, that is the time you must look at the other adrenal androgens. Now, this is all of academic interest only. To prove that, yes, there is a definite increase in androgen. And another use probably, if androgens are very high, then we have to rule out some androgen secreting tumors. If it is more than 150 and things like that, then it is relevant. Otherwise, to simply to have a practical diagnosis and treat them practically, clinical evidence of hyperandrogenism is more than enough, is what I want to tell today. However, these provide limited additional information in the diagnosis of PCOS. My take is ovarian androgens are most important to differentiate from other causes of PCO pattern, but then clinical evidence is good enough. No need to go for this high level, high quality assays.
So, sir, simply to the clinicians, that means any clinical features of hyperandrogenism, that is how you rightly said, the prolonged period of the irregular cycles, acne, hirsutism, we should not be doing the serum, all these testosterone, DHEAs, all these levels.
Yeah.
So, we can label her as an hyperandrogenism.
Yes.
But
Instead
if
of
we,
using the word should, I said we need not. I would use
we
the word.
need not. And if we feel there is a really alarming situations like clitoromegaly or very too
Yes.
many of the hirsutism,
Or
then
the or virilism, signs of
yeah,
virilism, that is
virilism, then
horse
we
voice.
yes, then we should go ahead by
Correct.
doing this test. Thank you, sir. Thank you very much.
Thank you very much. Yeah. What's the next question?
Dr. Preeti ma'am, you can ask the next question. Ma'am, you're muted.
Hear me?
Ma'am,
Hello.
can you repeat the question, please? Now we can hear you.
Good afternoon, everyone. Thank you, Priya ma'am, for giving me an opportunity. So my next question will be, you have explained very well, sir, about androgens. But previously we were taught like that we have to go for LH and FSH ratio also. So should we check for that?
I vividly remember in my MBBS days, the main thing they used to tell us there's an altered FSH-LH ratio 1:3. And if that is there, it is a case of PCOS. But somehow this FSH-LH ratio has taken a back seat now. Why it has taken a back seat? Because we all know PCO can be eugonadotrophic. That means there need not be elevation of LH also. Number two, PCO with regular cycles have hyperandrogenism with normal LH. We have seen all sorts of varieties of PCOS. There is hyperandrogenism, but there is no elevated LH. And one more thing, LH levels have no relationship with insulin levels also is seen in those who do not have hyperinsulinemia. All this leads to a conclusion that there is no need to mandatorily do FSH-LH. Higher LH is more evident in lean PCOS and is the cause of hyperandrogenism there. So since all sorts of possibilities are there, there is no need to spend money again in estimating FSH and LH in an adolescent girl. However, I'll put a rider. Suppose the lady is having infertility and she comes for an infertility investigation, then along with the investigations that we do for PCOS, we can estimate FSH-LH as a predictor for us to start the treatment. Suppose FSH is very low, then we know we have to give more gonadotrophies. Suppose LH is very high, then we know that we have to give GnRH analogs to bring down the LH. So there it is helpful. Shall I repeat? It is not necessary in adolescent girls, but when you are dealing with the case of infertility with PCOS, FSH-LH is required, but again there not to diagnose PCOS, but it is to treat a case of infertility. I hope I am clear in this.
Yes,
So
sir.
estimation is not mandatory to diagnose, but however, we have to do testosterone if at all. It may be done in cases of infertility.
Okay. Thank you, sir. Very well explained.
Thank you.
Can we have Alka ma'am with the next question?
मैडम को जाने के लिए बोलो. हाँ?
Hello?
And send the car back.
Am I audible?
Yes, ma'am,
Yes,
you're
ma'am.
audible.
So the next question is any tests for ovulations?
Yes, of course, we can do tests for anovulation because anovulation is one of the important problems of PCOS. In addition to whatever we said so far, that is estimation of testosterones, DHEAS, FSH, LH, we have to also do simultaneously other tests which are normally done for a case of anovulation. And this becomes more relevant again in a case of infertility rather than in adolescent girl. In adolescent girl, we don't have to bother about doing tests for anovulation, but we may have to still do certain tests to see why there is this kind of a problem, which may have other effects. You will soon realize when I talk about them. Number one, PSA. Now, we all know hypothyroidism is one of the known causes of anovulation, and is also a known cause of obesity. So if there are elevated TSH, then there is a case to start on, thyroxine for these kind of adolescent girls as well as infertile women. Prolactin is a very, very well-known cause of anovulation. Not only that, if there are any prolactinomas, if there are very high levels of prolactin, then it's a cause of concern both for an infertile lady as well as for an adolescent girl. We may have to bring down this prolactin, or if there's a big microadenoma in the pituitary, we may have to do surgical excision as well. And one caution here is while estimating prolactin, it should be fasting and mid-morning. What is that? The lady should be fasting. Mid-morning means not the early morning, 7 o'clock, 8 o'clock. She should go around 9 o'clock to the lab, and that's the time the numbers are correct. And if it is more than 100, then we have to give a neurosurgery consultation to rule out any macroadenomas. If it is less than that, then only we can start medical management. AMH, Madam Sandhya has been telling right from the beginning, AMH is one of the important markers nowadays for PCOS. It's a marker of disruption of follicular genesis right from the intrauterine life. So higher in those with amenorrhea rather than oligomenorrhea. So this shows that there are lots of antral follicles which are not reaching the level of primordial follicles. It is inversely proportional to benefit with the weight loss. So these are the three additional investigations probably are worth doing. I will little bit elaborate on AMH. Serum AMH level should not yet be used as alternative for detection of PCOS morphology. This is an indicator again in an infertile patient rather than in adolescent girl. Basically, what I'm trying to say right from the beginning, I hope all of you have caught it. In adolescent girl, a simple clinical diagnosis based on hyperandrogenism is good enough. There is not necessary to do an ultrasound because it can be misleading unless there are more than 20 follicles. There is no need to estimate the FSH-LH. There is no need to estimate even the testosterones. And unless the girl is obese and showing signs of excessive androgen, then only we need to do GTT. Otherwise, we should not bother the adolescent girl so much with these burdens of investigation, thoroughly investigating her and branding her unnecessarily as a case of PCOS. A single test of diagnosis of PCOS by virtue of AMH is definitely not recommended at this level. Maybe later they will come out with. So my final take on this is, yes, you can do TSH, prolactin, AMH, especially the last one in the infertile patients rather than in an adolescent girl. They will help us in management rather than in diagnosis of PCOS. This is management-oriented investigation rather than diagnosis-oriented investigation. What's the next question?
Sir,
Send the
before
way.
that, if I may just add one thing, what you rightly
Yeah.
said, very, very important. We are seeing lots of people just doing a prolactin, and if it is coming 30, 35, they are starting treatment. So what you very importantly said that you don't have to, because prolactin is bound to be a little bit high in these
Yes.
PCOS cases. So we have to look at
Yes.
in the holistic picture.
Yeah, you said it correctly, ma'am, because whatever we are using, bromocriptine or even the one, these are all like double-edged weapons. So any treatment is, especially hormonal interventions, can be sometimes double-edged. So a slight increase is not at all, that doesn't require any intervention. And in fact, it is said that you have to estimate on 2 occasions, spread the 3 months. And what is most important I've seen is that they go early morning. When they go very early morning, that you go fasting, all right, but you go mid-morning. Around 9 o'clock or 10 o'clock is the best time when the protein levels are settled. And again, even the diet is important. If you have taken heavy protein diet earlier day and all that, the product is bound to be shown a little higher. So that's why these are the interpretation and is very important of any lab value, and some common sense, like it will come when you become like Sandhya ma'am, the common sense will prevail. So what I mean to say, not only that, all of us, we learn over the years where actually I need to interfere, where I don't have to interfere. Soon after passing MD, we are full of knowledge. We start treating everything. Then slowly we realize everything need not be treated. Some oral treatment, uh, uh, counseling is also going to help them. You put it correctly. Yeah. Next question, please.
Very well explained, sir. Thank you very much.
Yeah.
What are the various phenotypes that we can see in PCOS, sir?
So, as I said earlier also, PCOS is not a single block. It will present us in myriad varieties. There are very, very, very many varieties. There is something called frank PCOS where all things are present. There is hyperandrogenism, there is chronic anovulation, there is PCO pattern, and it is very, very prevalent one. Then there is classic. I mean, frank and classic. There's a subtle difference. As you can see, it's almost the same. And driven. These are the tough ones. That's where, as I said, LH is normal in these patients. That's why we get confused. There are features of PCOS, but cycles are regular. This is a possibility. As I said, if there are 100 patients of PCOS, you will see at least 5 to 6 types of them. They are all not same. In some, there is hirsutism is prominent. In some, obesity is prominent. In some, acne is prominent. In some, there is mixture of all the three. In some, cycles are regular. In some, cycles are irregular. So all sorts of patients. There is a mild variety as well, where everything is plus minus, but PCO pattern is seen in the ultrasound. I think this is the one variety which most of the radiologists diagnosed variety, I would say, not to belittle their diagnostic acumen, because of the lack of experience, and they may be calling them as a case of PCOS, just looking at the pattern. So these are the different phenotypes. Next.
So I have the next question, sir. This is somewhat of an extension only. Since there are many phenotypes, isn't the clinical evidence of PCOS enough rather than the biochemical?
Exactly. That's what I have been trying to impress upon right from my beginning, that you should be a thorough gynecologist first, and you should have been seeing these kind of things and the treatment options and the treatment results. And based on that, you should diagnose rather than go purely on ultrasound. We can go wrong there. Purely on biochemical markers. So it should be a complete picture rather than a partial picture, which will always misguide us. And in all these things, experience counts a lot.
So, yeah, because what happens is many phenotypes, they do not have any clinical manifestations. That is one more
Exactly.
thing. And sometimes there are many androgenic situations, which are having so much of the clinical manifestations. So we cannot
Yeah.
quantify them unless
That's exactly why this slide comes up. As you correctly pointed out, the PCOS is a single syndrome in which the individual patient and not the phenotype should be treated.
Right.
So you don't treat according to the phenotype. So you treat it as a case of PCOS with your experience, clinical experience, and clinical diagnosis, rather than going by either a particular phenotype is there or whether a particular investigation is showing abnormality. You treat the patient as a whole.
Right. Yes.
Next.
What are the other causes of hirsutism, sir? And how do we differentiate?
So there are many other causes of hirsutism which will always confuse us with the case of PCOS. So even clinically also we should be thorough because we have seen like acne, hirsutism, alopecia. There are different varieties here. All of us know that. And there's ethnic variations as well. Like for example, in Southeast Asia where we belong to, there is central obesity, insulin resistance, diabetes, metabolic risk, and acanthosis nigricans. So the other conditions that will confuse us are non-classical congenital androgen hyper excess. So adrenal hyperplasia. So here, how to differentiate? In these kind of cases, 17 OHP will be more than 800 nanograms. This is where a biochemical test will help us in differentiating between the clinical diagnosis. The other cause of hyperhirsutism is that androgenic tumors. I told you in the beginning also, the only use of estimating testosterone probably is to differentiate between a androgen producing tumor and a simple case of PCOS. In simple case of PCOS, yes, there is androgen excess, but there is no tumor. Now, androgen tumor is dangerous. PCOS is not so dangerous. So how to differentiate between this? Estimate the testosterone. If it is more than 150 nanogram per DL, you are probably dealing with a case of androgen tumor, which has to be surgically removed. Right. Secondly, severe insulin resistance syndrome. This will be easily differentiated by doing a abnormal 2-hour OGTT. Cushing's. Here, cortisol will be less than 1.8 microgram per DL. That's how you differentiate between them. And finally, there is some entity called idiopathic hirsutism, where the serum androgens are normal. At this juncture, I want to clarify one more thing to everybody. There is a difference between hypertrichosis and hirsutism. If, especially in the south, if you go, most of the girls will have lot of hair. Even I have seen this in some of the North Indians girls. There is lot of hair on the arm, okay, and on the probably the legs. Now, this is not hirsutism. The excess hair on the arms, especially the forearms, is called hypertrichosis. This has nothing to do with PCOS. The hirsutism means the hair on the upper lip, that is in the mustache area, hair on the chest, and hair on the thigh, and hair on the back. This is hirsutism. So we have to make a difference between hirsutism and hypertrichosis. Hypertrichosis is simply constitutional. Some women will have excess hair on the arms, which is not a worry at all. A worry in the sense, cosmetically it is a worry, but medically it is not a worrisome. Whereas hirsutism is definitely worrisome. Along with PCOS, we have to rule out these conditions and then we have to treat the patient accordingly.
Sujata,
Yes.
you can have the next 2 questions. Ma'am, you're muted.
So now comes the $1,000,000 question, sir. How to diagnose this adolescent PCOS on ultrasound? Because everyone is coming.
Waiting for this question. So I gave a partial answer, but now I'll give the full answer. This is based on the new guidelines of ISHRE. So ultrasound should not be used for diagnosis up to 8 years after menarche. So they are with me. I was telling 5 to 6 years. They have relaxed it more. As I said repeatedly, one more last time I will tell you, the girls nowadays are attaining menarche at an earlier age, 11 to 12 years, and they will take good 5 to 6 years for their HPO axis to mature. Until such time, definitely there will be anovulation, irregular cycles, and if you do an ultrasound, definitely you will see some follicles. Now, just because you see some follicles, it is wrong to diagnose these young, pretty girls to have PCOS. So, ISHRE says, don't use ultrasound for a good 8 years after menarche due to high incidence of multifollicle ovaries in this stage. So then what we should do? Of course, they say TVS is better if the girl is sexually active, but we can't make it as a rule in India. We can't expect them to be sexually active. So a good resolution abdominal ultrasound is good enough. Then what is the threshold? This is the most important line of the slide. The follicle numbers more than 20 in either of the ovaries. Now, it is not each ovary should have 20 follicles. One ovary may have 10 or 12, other ovary may have 20. So 20 number is important. If one of the ovaries or both ovaries have 20, of course, there's no doubt at all. But at least one of the ovaries must have more than 20 primordial follicles. And by the way, how do you know these are the follicles of the PCOS? We all know a mature follicle is around 18 to 20 millimeters, right? So the PCOS follicles are less than 10 millimeters. They're usually less than 10 millimeters or around that, let us say 10 to 12 millimeters. So if there are 20 follicles, each measuring 10 millimeters, then probably she is a case of PCOS and not simply multiple follicles. Or the other criteria is size of the ovary. One of the ovary, either of the ovaries, should be more than 10 ml. Nowadays, most of the ultrasounds you can measure the volume. If you have 3D ultrasound, you can easily measure. So if it is more than 10 ml volume wise, then also you can diagnose PCOS. This is the criteria ultrasonic wise in an adolescent girl. Of course, to this, if you add the clinical criteria, and if you have the luxury of having a very good assay of testosterone, you can do that as well. And then, of course, as a routine investigation, you can do TSH and prolactin. FSH, LH is only when you're dealing with a case of infertility. AMH also for the infertility only. I hope I have now sort of totally summarized the thing.
Yes. Thank you, sir. So the take-home message is don't label them very early as PCOS.
Yes.
Thank you, sir.
Next question, please.
Dr. Kalpana, ma'am, you can ask.
Obviously, now that we have
Unmute yourself.
Now that we have totally understood what is PCOS, now we will be more interested in treatment strategies. So I'm sure the next question, logical question, is on the treatment.
Sir, I'm Dr. Kalpana Barapatre, and thank you very much, Priya Madam, for inviting us for this lovely session. And thank you very much, Murlidhar sir. You have explained it so well, and all investigations and all what we are supposed to do. So let's go to the treatment part now. So what are the treatment strategies and dilemmas in adolescent PCOS?
Yeah, one of the problems of understanding the subject very well is that we will become very theoretical, right? So theoretically speaking, the options are many. One is based on the complaint and concern of the patient. I think that is the right way of treating the patient. You may know so many things. You will know what is the cause of anovulation. It is metabolic syndrome, or it is HPO axis, it is obesity, it is insulin resistance. And you can't start treating all those things just because you have a theoretical knowledge. You ask the patient, what is your problem? The patient probably is only concerned about hirsutism. Then you just treat that. Patient may be only concerned about pimples. You treat that. Patient may be concerned only about irregular cycles. You treat that. So there is no need to just treat as per your knowledge. It is always better to treat the patient on the complaint base. This is one strategy. The other strategy is pathophysiology based, that is the theory based. because it is a metabolic syndrome, you blindly start her on metformin, no matter whether her glucose are abnormal or not, or you simply start giving her PCOS anti-androgens, thinking that it is an androgen excess. So there are two different strategies, but I prefer the complaint-based or a concern-based strategy as the strategy to go ahead with. So I would prefer a concern or a need-based treatment. Accordingly, you can give it. Optimize the combination of the drugs. For example, if you give her CC in an infertile patient, you may add metformin if you find insulin resistance, something like that. Yeah.
So, sir,
Anything else?
basically, we are supposed to do lifestyle
Yeah.
and diet, exercise. You have to tell the patient the diet.
It is based on the
weight
consent.
reduction
So let
for
me
proper ovulation.
Yes.
And if she comes in the adulthood for infertility, then we are supposed to give for the infertility treatment.
Yeah. So whatever is
only
the
cycle regularization OCs we can use, and anti-androgenic progesterones we are supposed to use in such cases.
We'll discuss on that. So before that, let us see what is this, what I mean by concern-based management. What are the concerns? There are three main concerns in an adolescent girl or anybody for that matter with PCOS. What is the first concern? The first concern is because of the anovulation. What are the problems because of anovulation? Number one problem is menstrual irregularity, right? All of us agree on that. Second problem is there is unopposed estrogenic action. That is why there will be fibroid uterus. Then there can be endometriosis, again because of the same endocrinological problems. And obviously, once she gets married and when she wants to have children, she will be confronted with infertility. So these are the basic problems of anovulation. And of course, finally, it may land up in an endometrial or ovarian cancer.
Thanks.
The second problem is, or a concern, is due to excess androgen. Now here, hirsutism is the leading problem. Scalp hair loss or the alopecia is another problem. Acne is the problem. Finally, all these things will end up in depression. The third concern, major concern, is that of a metabolic dysfunction. What are the issues here? Number one is obesity. Number two is sleep apnea. Number three is non-steatotic hepatitis, hyperlipidemia, and type 2 diabetes. Now, among these concerns, as far as, of course, cardiovascular events, which we cannot forget. As far as adolescent is concerned, these are the main concerns. What are they? Irregular cycles. Fibroids can occur even in the younger age group. Nowadays, we have seen endometriosis also can occur in the younger age group. And of course, the main issues are hirsutism, scalp hair loss, and acne and depression. And metabolic syndromes is obesity, sleep apnea, and NASH. So accordingly, what are the treatment goals? I'm sure this question somebody wanted to ask me.
Prasad sir, I think that.
What are the goals of the treatment considering the special age group?
So when we have listed the concerns, accordingly, we have to list the goals of our treatment, as because I said our goals should match with the concern of the patient. So our goals are, number one is management of irregular cycle. This is the utmost concern, especially of an adolescent girl. She is not worried about children. She is not worried about infertility. She is not worried about anything else. She will say, please treat my irregular cycles. That is her main concern, because she doesn't know when to carry pads. When she goes to school, when she goes to college, she's having cycles suddenly. So she is worried about this. That is the main goal. Second goal, equally important in adolescents, is the hyperandrogenic features like hirsutism, acne, obesity. So she is fed up of these three problems. The next, of course, the next stage, when she gets married, she will be worried about having pregnancy. So anovulation treatment is the main goal of the treatment. Then, of course, once she is having enough number of children, or let us say she doesn't get married, but her problem is, she doesn't know when she's ovulating. She wants to have sexual, life, but her concern is contraception. Then, of course, as the age advances, her main concern will be metabolic problems. So we have our treatment goal accordingly should be managing the metabolic abnormalities. And finally, prevention of the endometrial hyperplasia or cancer. So as I said, among these, first two are the goals of treatment in adolescent or young age group. Next two are probably for the reproductive years, and the last two are for the elderly or later years. So we can tackle one by one. Okay. So anybody wants to ask me how to do these things?
Dr. Vijaya ma'am, can you?
Yes, sir. So as you said, the first thing is the management of the irregular cycles. So which are the best way to manage the irregular cycle and which is the main concern in the adolescent? So can you elaborate on it more, how to manage the cycles?
Yeah. So as we said, adolescent girl is not worried about anything else except her irregular cycles. Now, when I speak internationally, I have to speak as a partner. But in India, we have to talk in terms of whether she's married or unmarried. Because when I first said in married women, she said marriage has nothing to do with the sexual activity. So that's why I have changed my slides slightly. In India, I'm using the word unmarried, but outside I will say whether she's single or not in relationship. In India also now it has become common, even unmarried girls are in relationship, and sexual activity is not not rare at all. Nowadays they are indulging in sexual activities. This irregular cycle comes in their way. So how to tackle this problem? If the lady, I will extend the scope from adolescent to up to adult age. If the lady is less than 35 years and if her BMI is less than 30, combined oral contraceptive pills are one of the best methods to regularize the cycle. But the flip side of this is that the lady or the girl has to remember to take the pills regularly every day, because if she drops the pills or she forgets to take the pills, that itself will cause the irregularity. And she should follow this very strictly. She should carry the tablets every day. Second, there is a worry whether the COC pills itself will increase her weight, because it is a possibility due to progesterone in the COC pills, the appetite increases, hunger increases, and they will tend to eat more. There is also retention of fluid sometimes due to estrogen part of the OC pills, and taking OC pills on a long term is not acceptable to most of the girls and women. So in this backdrop, the second best option is progesterone withdrawal. In fact, in last 30 years of my practice, I have only resorted to this method in all adolescent girls. The problem is convincing the mother and convincing the girl. They all think that the girl should menstruate 12 times in a year. That means at least once in a month. First thing we have to convince them is that there is no need to menstruate 12 times in a year, especially for the adolescent girls. But they must menstruate once in 3 months. Otherwise, there will be unopposed estrogenic action on the endometrium, which will give rise to endometrial hyperplasia. Now, how to achieve the cycles once in 3 months? The best method is to give progesterone, any progesterone you can give. Best is you can give 10 milligrams of medroxyprogesterone acetate for 1 week, or even other norethindrone also you can give for 1 week, and withdraw it. She will have withdrawal cycle. So this you have to give 4 times in a year, once in 3 months. This is as good as OC pills. In fact, it is better, and compliance is also better. Most of the girls will be happy with this. So if they already have once in 2 months, then there is no need of intervention. Let them go ahead with that. But if they have more than 3 months irregularity, they have to take the withdrawal with progesterone. This is not only to have the cycle, but also to have a healthy endometrium. I hope I am clear in this. The ladies more than 35 years, then OC pills are generally not advisable. So the second option, that is the progesterone withdrawal, is the best option. An additional option comes in these ladies that you can use LNG IUS. Abroad, LNG IUS is used by even the unmarried girls as a contraception. In fact, it came as a contraception, but as LARC, long-acting contraceptive method. But we understood the benefits of it. It will act locally to suppress the hyperestrogenic status on the endometrium, and it is better. So in the elderly ladies, best is to totally stop the cycles instead of having irregular cycles. But again, you have to counsel them properly, saying that once we insert LNGOS, after a couple of months, she will totally stop having cycles, and that is perfectly all right. Because many ladies still carry the myth that if they don't menstruate, bad blood is being collected in the pelvis. This is not true. We have to explain them correctly. So this is good, in fact, for her in the prevention of endometrial carcinoma. LNG IUS can act for 5 months. It will totally suppress the hyperestrogenic action on the endometrium, and you can replace it after 5 years. And once she attains menopause, you can totally remove it. So these are the different options for irregular cycles. And the best option, I would again repeat, progesterone withdrawal once in 3 months for the unmarried adolescent girls. For the married ones, of course, they are anxious to conceive. So don't treat irregular cycle. If they are anxious to conceive, giving some people think the ladies, especially not the doctors, hopefully, ladies think, doctor, my problem is irregular cycle. Once the cycle becomes regular, I will become pregnant. Please give me OC pills. Now they don't understand OC pills act by actually avoiding ovulation. They prevent pregnancy actually. They may regularize the cycle, but she will not become pregnant. So this education has to be given to a lady who is anxious to conceive. We must tell her, your irregular cycle, let it be there. Let us straight away go for ovulation induction. You become pregnant. You deliver 1 or 2 children as per your choice. And thereafter, if you have irregular cycles, that is the time we can give you either OC pills or progesterone withdrawal or LNGOES. I hope I'm clear in this. Of course, a married lady who is not concerned about the pregnancies, then the treatment is same as unmarried. Yes,
I just want to add a few points here, sir. When we
Please,
manage the
please.
irregular cycles, and most of these girls or these ladies are obese, so even we need to emphasize on the non-pharmacological aspects like maintaining the healthy lifestyle, diet modification, even reduction in the weight, like 5 to 10% reduction. Sometimes they resume into the regular cycles, so all these things are also important. The stress management, the sleep hygiene, all these things should also emphasize while we are talking to these girls.
Very, very nicely put, madam. Actually, it is there in my next slide. But you have anticipated that and you have answered it very beautifully. I totally agree with you that hormonal treatment is one thing, but personal maintenance is another thing. As you correctly said, even 5% reduction in the weight is going to help us so much in ovulation, especially for infertile patients. We first advise to reduce at least 5 to 10% of weight, which may take up to 6 months. We send them to physiotherapists, we send them to dietitians. And second part, yes, that is also very important. And sometimes, a regular exercise, which will not only help in reduction of the weight, it will also help in maintaining your mental balance, which is very, very important. And all those things will finally have, because the HPO axis is amenable to external stimuli, the stress or the anxiety or even the depression. So once the all these things are removed, HPO axis will automatically regularize itself, and she will have proper ovulation, and that's how this problem can be solved. Very good. I accept your inputs.
Very well explained, sir. Thank
Yeah.
you.
Dr.
So
Preeti.
yeah, so all these things I've already explained. There is no harm with the PCO or COC pills. Only thing is that you don't have to use sapropterin acetate containing pills straight away. It is a secondary choice. And metformin can be added if there is any insulin resistance noted. Yeah, next question.
Preeti, ma'am.
Yes. How to tackle hyperandrogenic issues like hirsutism and acne?
Yeah, this is a very, very important issue, and many people think that by giving some tablets, the hair will go away. In fact, I have given a thesis to one of my students in Manipal, where we use anti-androgens to get rid of the hirsutism. But our findings said when the patient is on the pharmacological therapy, yes, there is some softening of the hair, some delay in the hair growth, but the moment you stop, once our thesis was over, when we stopped the intervention, the hair came back with vengeance. It was like during COVID, we never went on tours, but after the COVID, we went around the world with a vengeance. So the best treatment for hirsutism is mechanical removal. What do you mean by that? Either you can opt for waxing, or go for threading or epilation, or even shaving. The only thing is, many girls do not feel like shaving, especially on the chin and on the upper lip. Of course, that is the time you can go for epilation. Better method nowadays, we have electrolysis and laser. This is for the well-established hair. No pharmacological treatment will get rid of the hair. Mechanical removal is the best. Then, is there any role at all? Yes, there is a small role you can give as a second line of treatment using COC containing sapropterin acetate, but not the first line. You can also give antiestrogen, flutamide, spironolactone. In fact, what we used in our thesis is flutamide, but flutamide has got liver toxicity. We have to be very careful about it. We should not give it more than 6 months, and there is no point in giving for 6 months also in a lifespan of 10-15 years. So that is exactly why I'm telling, while we are treating the PCOS in general, the side effect of the PCOS, that is hirsutism and acne, these have to be tackled in a different way. In that, hirsutism has to be tackled mechanically only. You can use finasteride also, but that also has got certain problems. People use metformin to reduce the androgen, but it is not a first line of drug. We should not misuse metformin at all. My take is, for well-established hair, mechanical method is the best. To soften and slow down the growth, you can use pharmacological methods. Insulin sensitizers have no role in hirsutism. As far as acne is concerned, you have to consult a skin specialist. Apart from bringing down the androgens, they will also have to treat the local infections, if at all, and that is very, very important. We should not be using all and sundry type of creams, because that itself can give rise to infection and problems. So it has to be jointly tackled by gynecologist as well as a dermatologist, especially the acne part of it, and even hirsutism.
So I have the next question, sir. The comments on ovarian drilling. Now seems to be some renewed interest, though it was considered obsolete some time back.
Yeah. No, renewed interest is for all the itching hands and and those who have bought laparoscopy. If not anything, let me do. If I have to give a quick answer, it should not be done at all. It is very harmful. I have seen many girls getting it done clandestinely through laparoscopic surgeons and then suffering infertility later in their life. So Yes, it acts by reducing intrafollicular androgen milieu. Theoretically, it sounds perfect. It has limited role up to 6 months, but after that, there is no benefit at all of ovarian drilling. It improves ovulation, but not cumulative pregnancy rate. If at all, it is advised in a very tough case of infertility. Definitely not in adolescent girls for irregular cycles and other problems. In infertility, there's a very, very limited small role to do this in order to achieve ovulation, especially which are what is called clomiphene resistant cases. Clomiphene resistant cases, there is a very limited small role of ovarian drilling, but there is an improvement in the ovulation, but there is no improvement in the cumulative pregnancy rate there also. So there is absolutely no role for ovarian drilling in a case of insulin resistance, and it is definitely not advised in an unmarried young adolescent girl. So it is not at all the first choice, even in married ladies. So many disclaimers I have put. Now I'll give some of the cautions. If after all that, if you still want to do it, please don't put more than 4 punctures. Please don't go beyond 4 millimeter depth. Use low electrical energy rather than high electrical energy. Cool the ovaries adequately with irrigation if you have used monopolar. And you must remember that the benefit is not there after 4 to 6 months. So whatever you want to do soon after drilling, either going for ovulation induction or going for assisted reproduction, do it within 4 to 6 months, because after that the effect weans off. It reduces the ovarian reserve and increases the adhesions. These are the two side effects of it. So I hope I have adequately answered your question of what is the role of ovarian drilling.
Yes, absolutely, sir. Like we said, it was considered absolutely obsolete. But as you rightly said, itching hands. Yes.
Yeah.
So can I add a comment, sir, with
Please,
your
please.
permission?
Yes,
So
please.
here the simpler way, we always say the rule of 4.
Yes.
That is how it is. And when we are using the electric current, it will be the 40 watts. And that is how it is easy to remember when we teach to the PGs. So
That's what I put it as
please.
4 punctures, not more than 4 punctures,
Yes.
not more than 4 millimeter depth, and don't give a gap of more than 4 months to take action.
Yes.
Yeah, you can wait up to 4 months for a natural ovulation and natural conception. Right. If they don't, then quickly go for the induction methods.
Right.
Yeah. So it should be a last temporary resort for ovulation induction. Next question, please.
Dr. Sujata ma'am.
Yeah, sir, so everything is done, ovulation stimulation and OC pills. So the crux is lifestyle modifications.
Yes.
So what
So
changes?
this is the most favorite topic of all of us, and we all love to talk about this, but it is very difficult for us only to practice this. We all say eat less, reduce the calorie, and change the composition of diet, do intermittent fasting. But I believe in this intermittent fasting. I have tried it on myself. Definitely, you will lose weight on this. That means I don't eat after 5 o'clock in the evening. Today I may eat because I'm already late. So otherwise, I definitely avoid eating after 5 o'clock. And the next breakfast is at around 8 o'clock, 5 o'clock to 8 o'clock or 9 o'clock. Best is that I don't eat anything. And during the eating window, what we call 9 o'clock to 5 o'clock, you can eat 2 or 3 times, and you can eat your normal things. But again, you have to watch your calories and composition. Not to say that, as earlier one of the madam said, it improves the metabolism also, and it also improves the ovulation. But metformin should not be used as the means to lose weight. Many people think that metformin, if at all, it helps in losing the weight because it causes nausea, vomiting, and gastrointestinal problems. So you don't feel like eating in the first 6 months. But once you get used to metformin, irrespective of metformin, you will start eating. So it is mental rather than metformin that is to be used. And not to forget all the 3 types of exercises. What do you mean by 3 types of exercise? Aerobic exercise, isometric exercise, and stretching exercise. So you have to mix and match. Couple of days you can walk, couple of days you can go to gym, couple of days you can do yoga, or you can do alternate days, these kind of things. So this is the best way to maintain a healthy body, healthy mind, and healthy ovaries. So control the portion composition and intermittent fasting. Do all three types of exercise is all that I want to say. It is easier said, but we have to encourage the even 1% loss of weight. We must encourage. Encouragement is the key. We have to appreciate that they have controlled their diet, they have improved their weight, and they are doing exercise. So that appreciation itself will encourage them to go further.
Yeah, and one more point madam has added is about sleep.
Yes.
Because one patient, she said she has online classes at 1 a.m. in the night. I said, what type of classes you are having at 1 a.m.? So they don't sleep also. This
At least that
adolescent.
girl is having online class, which sounds genuine. But nowadays, reels are the ones which will keep you woken up till
Yeah, so
1 a.m.
we have to see that they sleep in time and get up in time.
That is very, very true. In fact, to lose weight, you have to have a good 8 hours of sleep because during sleep, the stress hormones are reduced and they are the ones which will help in controlling the weight.
Yeah, that melatonin pills and everything
Yeah,
also.
yeah,
Pharma company will take on his.
yeah,
Thank you, sir. Yeah.
yeah. Next.
So since you mentioned metformin, what is the role of metformin in adolescent PCOS?
Actually, as I said, compared with placebo, the metformin group had improvement in plasma insulin and sensitivity. They also increased the good HDL and they reduced the testosterone, but there is no significant reduction in hirsutism. So it should not be used like a peppermint or a panacea drug. Many people use it like a vitamin. Metformin is now being misused, abused, maybe because of the pressure from the pharma companies. They are using metformin for everything: ovulation induction, reducing weight, for hirsutism, for sleeplessness, for steatoid, everything they are using metformin.
They are adding up melatonin also these days.
Yeah, so we must resist our temptation to use these drugs. So, but as far as prevention of diabetes also, it may not prevent, but once you have diabetes, then yes. Once you have insulin resistance, yes, but not to prevent. And it is no longer recommended for hirsutism. It is no longer recommended for weight loss either. You, if at all you want to start, you establish that there is insulin resistance in the girl, and then only you start. Otherwise, no. I think we are exceeding time like anything.
Yeah, I
Yeah.
know.
So we'll just wind it up. So
Is
these are
Dr.
some
going on well.
Vishwas has joined.
slides. Yeah. So contraception question in adolescents comes up if they are sexually active only. Otherwise, no. But you can definitely use these contraceptive pills. But if there is a risk in a lady, they better avoid risk of stroke and risk of heart disease. This should be avoided.
But
And
there
if
is
they
a
have,
question, role of myoinositol. Normally we keep
yeah,
on giving so much. Is
yeah.
it?
Myoinositol also is being pushed heavily by the pharma companies. This is a milder insulin sensitizer compared to metformin. If there is no place for metformin, I wonder whether there is a place for myoinositol, is my answer. Okay. So the last
Dr.
two
Vishwas,
questions.
Metformin in
Parulekar.
somebody's asked the question. Now, metformin in
Dr.
prevention of preeclampsia. Your comments on that, sir.
Metformin does not prevent preeclampsia as such, if I can understand. It will definitely help in bringing down dyslipidemia. It will bring down GDM because GDM and preeclampsia are close cousins in a way. There is a total metabolic disorder there. So, if the patient has insulin resistance during pregnancy, then there is a case for starting metformin. Uh, a small role of metformin in prevention of abortion is mentioned, but it is not a abortion preventive drug. If the patient was a case of PCOS and you used metformin for ovulation induction and she was successful in becoming pregnant, then there is a case to continue metformin up to first trimester, which may help in prevention of abortion. But if the patient was not a case of PCOS, she conceived naturally, there is no role of metformin to prevent abortion. Similarly, there is no role of metformin as yet to prevent either GDM or preeclampsia. However, if the patient develops insulin resistance in the second trimester, you must first start with metformin. If it is not controlled with metformin, then you can add insulin. This is what, to the best of my
Dr.
knowledge.
Rajendra Chavan, do you have any? Dr. Rajendra Chavan has also joined. Dr. Rajendra Chavan, sir, do you have any? Okay,
No,
we'll go ahead.
it was an excellent presentation, and sir has comprehensively taken everything right from A to
Yeah,
Z, and there is no doubt remaining. But definitely, it is a long-standing story. So we have to continuously motivate and pursue, and that is what Muralidhar sir has guided us. By
yes.
you have to continuously be behind that. Only thing what I wanted to add was, okay, they should not leave the thing in between
Yes.
because there's a tendency that they go on and thoda ho gaya, बाद में they get
Yes, sir.
this bored.
They
So you
get
have to,
bored or frustrated very quickly of taking either the tablets or following the lifestyle. We should coax them, convince them, encourage them, appreciate every step of improvement, and that's the way.
Dr.
yeah.
Vishwas has also
Thank
joined.
you.
He joined little late, our another panelist. So, Dr. Vishwas Parulekar from Navi Mumbai. Okay, yeah, we can go ahead. By the time he will take it up, yes.
Yeah.
So, how to manage depression and anxiety, sir?
Of
Overall,
course,
everything.
the best way to handle this is to hand over to the psychologist or even a psychiatrist. I think psychologist will take care of this part actually. It is very, very obvious that a young girl with obesity, hirsutism, and acne to feel a little bit of depressed and anxious. We have to, as I said, resort to counseling ourselves. We have to, give her the right advice. We have to give her the right guidance and the right kind of treatment, and also encourage her at every step of improvement. But more importantly, we have to go for the psychological interventions there. So it is definitely a cause of concern to the parents as well. If the simple counseling doesn't help, you have to think of starting antidepressant, but their role and efficacy is not established in women with PCOS and anxiety and depression. But I think I would leave it to the best of the knowledge of the psychiatrist. Women with PCOS have impaired quality of life and higher depression and anxiety compared to women with similar BMI with PCOS. So again, the efficacy in this part also is best left to the judgment of the psychiatrist. I think it's time for us to wind up. If there are no questions, I will try to summarize this. Sum and substance of what I have told so far is PCOS is a hyperandrogenic state, especially of ovarian origin, less of adrenal origin. Clinical or chemical evidence of it is a must to diagnose, apart from other things like ultrasound diagnosis of PCO pattern or obesity or insulin resistance. The most important and simple diagnosis can be made by clinical evidence. We can prove it further by doing GTT to prove the insulin resistance, especially in the obese ladies before starting the metformin. Treatment should be based on the symptoms and the need rather than our understanding of the PCOS. If the patient is not worried about a particular thing, you don't have to force the treatment on her. COC pills or progesterone withdrawal once in 2-3 months is a good strategy for a menstrual irregularity, both in a married as well as unmarried. But if she is particular about fertility, you should not start COC pills. Rather, you should go for ovulation induction straight away. And as far as hirsutism is concerned, mechanical removal is the best method. Pharmacological treatment has got very limited role of softening the hair and delaying the hair growth, but we cannot use it for a long term. Moreover, they have got very bad side effect on the liver. Pharmacological agents, as I said, they will just delay the growth. Weight loss by any means, by intermittent fasting or by your portion control, lifestyle changes, exercise, everything is welcome. Ovarian drilling should be a very, very last and temporary resort, as a very limited load in a clomiphene citrate resistant cases only. Thank you so much for this opportunity, and thank you so much for enduring us for such a long time. But I hope some good
The
has been
topic
done.
was so good and so intriguing that, it was truly, I didn't want it to interrupt at all because it was so much important that we understand PCOS in the better perspective and the better aspect, and don't do any over treatment or don't do under treatment and don't do over investigations. I mean, we really don't know what we are doing and we're just like a big hodgepodge out there, but you have really cleared it so, so well, Dr. Pai.
Thank you so much.
Absolutely great. Yes.
And I thank all the panelists who are so erudite, so knowledgeable, so experienced, and they helped me in putting things together. And wherever I have heard, they have bridged the gap, and they have added very, very usefully to this.
Excellent discussion. All the panelists, sir, everyone are, expert in this field, in their
Of
own
course.
area, and they have really thrown light. I think all the audience, and this is a recorded statement, the thing also are really going to get benefited with this. And Dr. Pai, I must really thank you from bottom of my heart because you
Thank you.
really patiently took this up. It's not that you just had to finish it off. No, you have really devoted the time. That shows your devotion. That actually shows your devotion, and why are you called the brightest mind of the nation is what we understand today.
Thank you
Is
so
you
much. Thank
are
you.
really putting your whole thing into it and making it understand. Absolutely hats off to you. Thank
Thank
you
you.
Sir,
very, very
Yeah,
much.
thank you.
Madam, on the behalf of all the panelists, we would like to thank Priya Ganesh Kumar Madam for giving us this opportunity, and Dr. Pai for putting such efforts and inputs and changing our perspective towards the management of PCOS. Thank you very much.
Thank you so much. Thank you so much.
And stay tuned. We are coming back with the next session. I know it's gone late, but I think it was all well worth evening being spent with the right minds. So our understanding becomes great.
Thank you,
Yes,
sir.
Ananya. Yeah.
And thank you for to all the panelists for such an enriching session. So let's go on to our second session. It's a case discussion on CIN management. For this, let me call our experts, none other than Dr. Priya Ganesh Kumar ma'am, without whom this webinar wouldn't be possible. She's Managing Director, Sainivas Healthcare, a chain of
Yeah, it's
pivotal.
already done. Already, Ananya,
Yeah.
we can go. All are our friends.
And Dr. Anaga Diwan ma'am, Medical Director, colposcopist at Aurangabad. She's the first WHO certified colposcopist in Marathwada. And she's also a WHO IFCTC and ISCCP certified colposcopist and a master trainer. Dr. Sandeep Phadke sir, Managing Director, Phadke Hospital, Akola, past President, Akola. And he's also a WHO IR trained master trainer who's been a faculty for various colposcopy workshops. Welcome, experts. Now I hand it over to Priya ma'am for the case discussion.
Dr. Sarita is also there, is she?
She's
all right. Dr. Sarita is also there. Anyway, so now after this wonderful session on PCOD, can you switch off this and share? Let me share my case. Yes. So now here we are with the wonderful case. It's a routine case, and I do have my a lot of take-home messages with this case. Okay, now let me read through this case for you all. The case is the patient profile is this is a patient of 30-year-old, and she has actually no complaints. This is where screening actually plays an important role. I was HOD of one of the highest, high put center, and it had to screen around 5 lakh women. So in this preventive oncology center, it is a high footfall area, and since every day we have to screen around 100 to 200 women, and it's a high resource area setting. So that means we have the whole biomolecular lab system in this thing with us, in tune with us. So she walks in, she's a routine lady, just usko bola hai, that's why she comes into the screening. That's it. The menstrual cycles are normal. She's got one 8-year-old daughter, and that's it. She comes to this center. Now, in this center, we are also having, it's a research center as well. So we do have mRNA, we have got HPV DNA, we have got PAP, and we were doing some research also with mRNA. And basically, the whole working was that she comes for VIA, the staff nurse who is a qualified staff nurse. She does her VIA and as well as takes the sample. So her VI has been done, and I get the evening report, about 150 ladies ka report I get in the evening, that the staff nurse has mentioned as screen negative. And her then her screening ka report, which is because her molecular test comes after say 2 or 3 days, her report came up cytology as NILM and HPV 16 positive. This is her report. But her VIA has come negative. Right. And now from here, what we gain, Anaga, Sandeep, you can join me over here. Having this 16 positive, how do we go ahead then?
Yeah. At first, I would like to thank you, Priya Madam, for giving me opportunity for this prestigious webinar. Thanks a lot. And it's my absolute pleasure to be a panelist in the panel of or in this
Welcome,
program.
Sarita also.
Ma'am,
Hi.
sorry to interrupt.
So happy
Dr.
you've joined.
Sarita Balerav ma'am is here.
Yes, she is
I'll just
Secretary General
introduce
of
her real quick.
ICOG. We are very,
Dr.
very
Sarita
privileged.
Balerav ma'am is a consultant obstetrician at various hospitals in Mumbai, like Bhatia, Saifi, Reliance, Breach Candy Hospital. She is Secretary ICOG and immediate past president, past chair of AICC RCOG West Zone, and past president Mumbai OBG Society. Welcome, ma'am.
Thank you, Sarita, for joining. Sarita.
Thank you for inviting.
Yes. Yes, go ahead, please, Anaga. Yeah.
Yeah. So as per WHO guidelines, every female, at least she should undergo with primary HPV testing regardless of her complaints. So she should undergo HPV test as a primary screening test for cervical cancer. And we are seeing the result that though she is not having any complaint, she has been come as HPV 16 positive.
So in such case, what exactly should you be actually, Sarita and Sandeep also can join me. I mean, should we wait with these results of PAP NILM and VIA negative? Or should we go ahead? Yes, Sarita, Sandeep, anyone
I
can
think
just.
we should do a colposcopy definitely, because HPV 16 is a high risk HPV, and we know that almost 80% of cervical cancers due to 16 and 18. So I think definitely we should go ahead with a colposcopy, and if there's something on the colposcopy, a biopsy.
So again, just to shed light, this is a high resource setting. We were doing some research on mRNA, and invariably 16 was also triaged with mRNA, which came positive. So mRNA being positive, Dr. Sandeep, what exactly we actually think about it as well?
As the mRNA is positive, now probably the patient is having some kind of a transformative type of an infection. It's not only the infective or the inflammatory stage. She has already into the transformation stage. So now you have to take it very seriously and go ahead with the thorough evaluation of the patient, and especially with the colposcopy only.
So here is a colposcopy images which I have put, and something which we really can understand is anyone want to take a talk about these images?
The colposcopy seems to be adequate. Then the squamocolumnar junction, it seems to be into the cervical canal, and with the help of an endocervical speculum, we were able to see the one of the its border which is inside the cervical canal. On the application of the acetic acid, there seems to be faint acido-white area which is almost occupying whole of the cervix, especially the lower quadrant of the cervix, occupying almost 50% of the cervix. So even the lugal iodine was not taken up.
So here is something which comes to our mind. Like when I did this, it came to my mind, why did my staff nurse, who is well trained with VIA, well trained with a certified VIA performer, why did she say as negative? Now, this is somewhere take home message for all our delegates comes in. Whenever we do a VIA, we are applying it for 1 minute and we are supposed to wait for 1 complete minute. That's exactly where my staff saw the whole thing and thought this is a sort of an ectropion and said it is negative. I mean, it's really very surprising. But such things can happen. That's what I brought this case for. Yeah. Yes, Anaga.
In the first picture, madam, it is immediately after application of acetic
Yes.
acid. We can see dense acito-white area, which is the columnar epithelium. But in the third picture, that acito-whiteness has completely disappeared. And that is the difference in between a lesion and
physiological acetovateness.
That is metaplasia. This is the whole
Yeah,
thing.
this is
Exactly. This picture makes our understanding very clear. First of all, and again, you can see over here, this area, it's a dense area. You can see this coarse punctations as well. And again, this lesion is going inside. So suppose if you have to sweet it, anyone can throw light quickly. The sweet scoring of this would be, for acetoviteness, we put it up as say 1 or 2.
2.
Then for margins, we put it up as 2 because it's a raised margin. 2. Then for blood vessels, we are putting it up as 2 because it's a coarse punctations and coarse mosaics which we see over here. And for
Lesion
size
size,
is going inside, so we put it up as 2. And here is you can put it up as 1. So somewhere it is coming around to 7 to 8, which is a HSIL. So histopath was taken, and that's showing CIN2 and CIN3. And since again this is going inside, we did have to do endocervical curettage. That was showing us normal. And this is her microscopic picture where you can see very confidently there's a CIN2 over here, some places CIN3 as well. So having this, what should be our next step then? I mean, knowing this, what should be our next step now? Sarita, will you want to take it
So
up?
I
Like
think what you've done is perfect. You've done a large loop excision of the transformation zone. So you have removed that area, and this procedure is both diagnostic in terms of histopath as well as curative. And then the sample has to be examined very carefully for the margins and to show what it says. And this thing, I can't see, it shows mild to moderate.
It showed CIN1, CIN2. It had the margins being free of margins. So it was
The margins are free.
completely taken out. And so it's a large loop excision of transformation zone. Another thing which is again a point to be understood, what is a leap and what is the difference between a leap and, because we are always talking about leap and let's going, interchangeable. Leap can be used for a biopsy, but for treatment, it has to be large loop excision of the whole of the transformation zone, which was done here. And then follow up. Then follow up becomes, it's now 6 monthly. We called her up for a relook colposcopy and a test of cure. Now that's exactly where Anaga just mentioned that HPV, where now WHO 17 November we all celebrated the fourth WHO day of World Free of Cervical Cancer call day. Now WHO states that if you have to truly start understanding these cervix and all, use an HPV test, because the test of cure becomes brilliant when you use, HPV test. So as a test of cure, you can do this at 1 year. But now another understanding has come up. The recent understanding is you can do a test of cure at 6 months also. Nevertheless, suppose if 6 months may even their HPV is positive, don't worry, don't get nervous. It takes time, HPV takes time till 1 year to sometimes even 1.5 years to go away. But you can still do it, but we normally start doing it at 1 year. That's what we have been doing. But relook colposcopy is always done. This was a relook colposcopy. And we see here there was actually no lesions and it's completely cured. And yes, test of cure was done, which was again negative. And the insights. Here, this case, why I have brought it, if we had done a PAP test for her, which is NILM in this case, it have been a little bit of a, under, because we know that PAP test is 40% false negative. And having said so, mRNA positive case of SIN2, SIN3 would have slowly, rampantly rather, progressed ahead. That's one thing which we have to understand. So VI again is a subjective test. HPAP is again a subjective test. So it is the HPV which actually raised the alarm in this case. So I stopped sharing my screen here, and I do want to know from our panelist. And I really want you all to give message to our participants who have joined. How do we go about with such type? How should you think about such cases? Here the patient is asymptomatic. She is not symptomatic at all. She's sitting nicely in her house. She's a staff nurse herself, and she was just coaxed in because it was a program run by Thane Municipal Corporation. She was coaxed to go into this screening program. Yes, I start from Dr. Sarita. What is your take-home messages for all our participants?
So I think that one of the important take-home messages is that our primary screening for HPV is in. Co-testing is the best way to screen for cervical cancer, and I think that pre-test counseling is also very important for these patients because I see in my practice they get very scared and very worried when the HPV comes positive. So I think that these are the important things, but we have to reassure them that if it is treated well and it is managed well, they will not develop cervical cancer. I think that's our overall message.
Yes. Anaga, Sandeep, yeah, you can take it up. Yeah.
Actually, whenever you are doing any kind of a screening test, you have to explain to the patient what is the sensitivity and the specificity of that particular test. Because many a times with PAP, you get false negative. That means many of the times the test may be normal, but patient may be harboring some kind of an cyan lesion. So uh, just looking at the PAP smear or telling the patient that once it is normal, you don't have to worry, come after 3 years, I think it is always better to do some kind of another test or try with some kind of another test, like a simple VI test. Because the pap smear, if you look at it, the sensitivity is low, but the specificity is very high. That means whenever you find some positive finding in the pap, you have to be very serious. But when it is negative, you don't be relaxed. You try with some or other test. So I think trying with some or other kind of a test is important whenever you are doing the screening test.
Or having a sequential. I mean,
Yes.
what happens is, and actually it is even in whenever we teach about this medical legal aspects of, cervical cancer screening, we really stress this point that please talk to the patients that this is a subjective test. You are supposed to do an HPV test as a primary screening test, and please put it down on her paper. That means you're also safe that, yes, you did advise. If she hasn't taken it, the ball is onto her court. But now the era is a medical legal era. So please, my dear friends, this is one take home message which you all will really take it up from here. Advice and HPV test is very important. I'll tell you one story over here. I had gone for one of the workshops at Chennai, and they are this infertility chain of infertility centers at Chennai. And there the discussion propped up that this chain had one medical legal problem because they were doing an embryo transfer and the patient is 6 months with them. And then they realized that this is stage 1A1 or stage 1, something that cancer. So it was already a squamous cell carcinoma. And then the patient said, I am there with you for 6 months. And how come you didn't even understand that I have a cancer? And now you're telling me after 6 months that there is a cancer. So please, dear friends, HPV is an extremely important tool for you all. Yeah. So that's one thing. Yes, Dr. Anaga.
Yeah, HPV 16 and 18 positive if possible, or it should be an absolute indication for colposcopy and if necessary colposcopy guided biopsy.
Yes. And the last take home message which I would like to get to all my dear friends are VIA. Now we are doing VIA. Don't be in a hurry. Why VIA programs didn't succeed? I'll bet the fact VIA is the chosen method in government of India because it is economical. But only thing is, it is reproducible. I can't question it because sometimes, but interpretation of VIA is extremely important. So you should have your QC, QA in place. So when you're doing a VIA, you apply for 1 minute and then you wait for 1 minute. That waiting 1 minute, we don't do. And that's why either we say this is whole thing as positive, ectropion looks like a positive. Or we lose out thinking, oh, ye to ectropion hai, ye to normal hai. And that's how exactly this case was a case which made all of us understand the importance of where all mistakes can happen. So that's one thing which I wanted to get for you all. And I think, yes, we have come to the end of our session. And thank you very, very much. Dr. Sarita, Dr. Sandeep, Dr. Anaga. You all are experts in your own field, how very well you all conduct, and in all different places you have been doing colposcopies. You all have been the masters, you all been the teachers as well. So thank you very much to join this program.
Thank you.
Thank you, Priya.
Thank you, Priya.
Yeah, thank you.
Thanks, ma'am.
Bye-bye.
Thank you, doctors.
Thank you to
Yes.
the experts for this enriching session. Now we can go for the vote of thanks.
Over to Rashmi.
Thank you, doctors. We had some excellent discussion so far. To wrap up today's session, I now invite Mr. Abin, Product Manager, Genworks, to share the vote of thanks. Over to you, Abin.
Thank you, Rashmi. Today's section was very insightful. The evidence-based insights, case discussions, and the clinical outcomes shared by our experts contribute to strengthening the clinical practice and improving the patient outcomes. And I would like to thank each one of you for the excellent support on the particular webinar. And especially, I would like to thank Dr. Ananya for conducting the section very smoothly and excellent. A special note of appreciation to Dr. Priya Ganesh Kumar, who has been the brain behind the CWS webinar. And I would like to thank our esteemed guest of honor, Dr. Kiran. I would also like to thank Dr. Muralidhar Pai for upcoming with insightful discussion on the management of PCOS, along with the panelists, Dr. Alka Kumar, Dr. Sandhya Sharan, Dr. Vishwas Parlekar, Dr. Preeti, Dr. Varsha, Dr. Ganesh, Dr. Sujata Kulkarni, Dr. Kalpana, Dr. Prasad, Dr. Vijaya, who really added a flavor to all the discussions. The case discussion by Dr. Priya Ganesh ma'am was truly insightful and excellent. I would like to thank Dr. Agada, Anagha Diwan, Dr. Sandeep, Dr. Sarida for their exceptional contributions in this case discussion. We also thank our wonderful participants for joining with us and making this an engaging learning experience. A huge shout out to the amazing Genworks team for the support and coordination and effort, enthusiasm and excellence behind the scenes. Thank you.
That's on 4th. So there'll be a reverse panel on another very, very interesting and important topic, preeclampsia. Where are we? And I invite one and all to be tuned, and that's on 4th of December. And we have with us another wonderful orator, teacher, and he has done his own research. His research article has now been published, and he has got great insights into it. That's Dr. Bellard. So he would be moderating another reverse panel, and we have host of panelists with us who are really going to shed light. And who else can we expect as guest of honor is our own Dr. Meera Agnihotri, Padam Shri, who has done lots and lot of work onto this field. So thank you very much, everyone. Please stay tuned and look forward for 4th December webinar. Thank you very much, Rashmi. Thank you, everyone. Thank you, Anaga, and everyone, and Dr. Ananya to conduct this program excellently. Thank you very much.
Thank you, everybody.
Thank you, everyone.